A 39-year-old Caucasian woman named Patsy Stone came in 12 days ago to the urgent care clinic smelling strongly of cigarette smoke and complaining of fatigue. The woman reported no obvious reason as to why she should feel fatigue, but she is always feeling tired and not absolutely fabulous. As a result, I ordered a blood smear test and a metabolic panel. The metabolic panel presented with the following results: a low red blood cell count, also known as erythrocyte, value of 2.8 milliliter per deciliter, a low hemoglobin count of 9 grams per deciliter, and a low hematocrit of 26.7. White blood cell count differential was normal. The blood smear test came back from the pathologist, and it was noted Patsy has moderate macrocytic anemia with presence of many stomatocytes. No significant abnormality of white blood cells, also known as leukocytes, or platelets, also known as thrombocytes. These red blood cell findings are not specific but can be seen in response to medication, alcohol abuse, and poor nutrition, also known as malnutrition. I called the patient back to talk and order more tests. The patient admits to a history of alcohol abuse, but none since last night. It should be noted that the time is 11:15 a.m. on a Tuesday. Patsy states that she is eating a normal diet and does not admit to eating a significant amount of fast food. It should be noted that her weight is 160 pounds and that she is 5 foot 8 inches. Hence, her anemia cannot be explained by the nutrition problem. When asked about the medication she takes, she stated that she takes pills only as they are given to her. Upon the second visit 7 days ago, I asked Patsy to go in for further testing to measure her ferritin levels and her iron levels in her blood. The ferritin level of 460 nanograms per milliliter, which is significantly elevated above the standard range, in addition to her high iron level, which was 199 micrograms per deciliter. Her percent iron saturation is 57%, and the highest of the standard range ends at 45%. This suggests iron accumulation in her blood is higher than normal, also known as iron overload. Hemochromatosis is suspected. I asked the patient if there was a history of hemochromatosis in her family, and she did not know if anyone in the family had the disease or had been tested for hereditary hemochromatosis. I recommend the patient to genetic counseling and to get tested for the hemochromatosis, also known as HFE gene mutation. A mutation in the HFE gene will correlate with the prognosis of hereditary hemochromatosis, causing a secondary macrocytic anemia. Recommended treatment is phlebotomy.